with us Professor Mary Abraham. She did a MD from the prestigious AIMS Institute, and followed by DNB, FICA, and Diploma in Hospital Management. And she's a neuroanesthesiologist and a pain and palliative care physician. She's presently working as a visiting consultant in Max Hospital, Panjshir, and also in Max Institute of Cancer Care, Lajpat Nagar, in Indian Spinal Injury Center in New Delhi. And she also runs a private clinic at Vasant Kunj in New Delhi. She was awarded the Lifetime Achievement Award by the Delhi Neurological Association for contribution to neurosciences in Delhi in February 2000. Main interests: pain and palliative care. She's also authored a book, Conquering Pain, in 2009. We're very honored to have you with us, ma'am. So since it's 7 o'clock, I think we can move on to the first session, to the first topic.
Thank you so much for that warm introduction. And as usual, am I audible to everybody?
Yes, Dr. Mary, you are.
Okay. And I'm very honored once again to take this presentation for Pallium India. And I'm glad to be associated with the Pallium so that we can reach out to so many people and share notes with each other. And I also benefit from listening to you people. And of course, I have all oncologists with me. And I'm really highly honored to give this talk. So without much ado, let me start with my slides. I'm going to share the screen. Just one minute. The topic of my the broad outline of my talk is on definition of pain, the basics of pain mechanisms, the WHO definition of palliative care, and a multimodal approach to pain management. It's quite a large presentation. Actually, I mean, it's 40 minutes is not enough, but I'll try my best to complete it within 40 minutes so that we can have a time of interaction with each other. Okay, so let me start off with what is pain. Now, pain is actually a biopsychosocial experience. It is not just an unpleasant physical sensation because it encompasses mental suffering as well. In 1977, G. Engel, a psychiatrist, floated the biopsychosocial model for any disease, including pain, in which he said the mind and body are not discrete entities. They tend to affect each other. Physical injury can have a psychological and social impact and vice versa. In 1960s, it was Dame Cicely Saunders in the UK, who was a founder of palliative care, had already floated the concept of total pain, in which she described the inseparability of physical pain from mental suffering. And she had, quoting her, much of our total pain experience is composed of our mental reactions. So this is the biopsychosocial model, which was proposed by Engel in 1977. I won't go through the details of it. You can go through it later on when you see the slides because of paucity of time. And this was the total pain concept that was proposed by Dame Cicely Saunders, in which she said that she was talking specifically about cancer pain, in which she said there's a physical pain, there's a psychological pain, there's a social pain, and there's a spiritual pain. Later on, I will discuss a case in which we will see all these aspects. Okay. Now, surprisingly, the definition of health by WHO also has a similar concept, in which it is said that health is a state of well-being in the physical, emotional, social, and spiritual dimensions. Now, the definition of pain in 1979 was by the International Association of Study of Pain, in which they defined it as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. But there was a lot of criticism over the years for this particular definition because certain types of pain can occur even without tissue damage. We see patients with psychogenic pain, with fibromyalgia, where without any tissue damage, they are having a lot of pain. Or there could be minimal tissue damage, like in neuropathic pain, where a simple cut can lead to a lot of pain, or a chronic regional pain syndrome, where the tissue damage is minimal, but the pain could be very high. So that is why there was a criticism of this, that it is not entirely due to tissue damage. So subsequently, the current definition of pain, which was revised in 2020, by the same International Association of Study of Pain, says that it is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or resembling that associated with tissue damage. So that means tissue damage need not be present for pain to be present. So that is how. Of course, there have been more updates on this definition. If you go to that website, you'll see what else they've added to this definition, but this is a basic definition. A simpler and more realistic definition of pain was given by Margot McAfee in 1965, when she says that pain is whatever the experiencing patient says is existing whenever he or she does. In simple terms, pain is what the patient says hurts. Now, having gone to the definition, let's discuss the mechanisms of pain. How is pain, pathophysiology of pain? How is pain ultimately perceived by the body? Now, nociception. Nociception, nocere in Latin means harm or hurt. So nociception is a process by which information about actual tissue damage resulting from a harmful or noxious stimulus, or the potential for such damage if the noxious stimulus continues to be applied, is ultimately related to the central nervous system, and pain is perceived. That means nociception is a process by which pain is perceived. Now, it was Descartes in the 16th century. He first alluded to the pathway of pain in his book, The Treatise of Man. And with great insight, he wrote that as fire comes close to the foot, here I can show it to you, the painful stimulus led to the pulling of a delicate thread that ran up the leg of the boy to the brain where it was perceived. So this was the first reference to the pain pathway, how pain is transduced, transmitted, and perceived by the brain. Even today, this classical pain pathway, or the Cartesian model of pain pathway, is still accepted in parts. Of course, there are modifications to this, but the basic thing remains the same, where it starts with transduction at the periphery, transmission of the electrical impulse, the perception at the brain, and the modulation that occurs because of the descending inhibitory or facilitatory impulses. So what is transduction? This is the role of the nociceptors, that are the peripheral nerve endings present in the various parts. It can be the skin, in the viscera, in the muscles, in the joints, in the meninges. And this is a process by which the noxious stimulus, whether it is a mechanical, thermal, or chemical stimulus, is converted into an electrical signal. That's why it's called transduction. And the nociceptors are the specialized nerve endings that are present in these various regions. This pain signal, once it is converted into an electrical stimulus, it is transmitted through the peripheral afferent neuron, or the first order neuron, to the central nervous system. So here we see that the pain impulse is transmitted by the A delta and the C fibers. Okay, there is also the touch, which is being stimulated by transmitted by the A beta fibers. Anyway, they all go through the dorsal root ganglion and enter the spinal cord, the dorsal horn of the spinal cord. Okay, and where it synapses with what is called the projection neuron, or the second order neuron. So the transmission of pain as an electrical impulse from the site of transduction to the central nervous system, that is the transmission of pain. And like I said, it is transmitted by the first order neurons, which are predominantly A delta and C fibers. Now, if you look at it here, again, I'm saying the same thing. A delta and C fibers are transmitting the pain. But these are either thinly myelinated or non-myelinated. C fibers are non-myelinated. And the diameter is also much less as compared to the A beta, which transmits the touch, or the A alpha, which transmits proprioceptive impulses. As a result of its being lack of myelination, the speed of conduction is also very slow as compared to touch and proprioception. So that is all depicted in this diagram over here. Now, the dorsal horn of the spinal cord is the first major relay center for the pain impulse. That means the peripheral first order neuron is coming, the cell body is the dorsal root ganglion, and it is coming into the dorsal horn, where it is synapsing with the second order neuron or the projection neuron. It's called projection neuron because ultimately it is projecting upwards into the brain. So this how it's transmitted. It's transmitted by the release of various excitatory neurotransmitters that are released in the synapse between the first order and the second order neuron. They could be glutamate or neuropeptides like substance P. And these activated projection neuron or the second order neuron project the pain impulse to the brain through pathways that are ascending upwards from the spinal cord to the brain. So this is the second order neuron. We said that it is crossing over and it is going upwards. So one is the spinothalamic tract, that it goes up to the thalamus, and from there it projects to the somatosensory cortex. There are also projections to the periaqueductal gray matter, and this pathway is responsible for localization of pain. There is also another ascending pathway, which is a spinal reticular tract, which goes on the way before going to the thalamus. It is going into the brainstem reticular formation before reaching the thalamus. Ultimately, it is going into the limbic area responsible for the emotional aspects of pain. That is, it's going here as well as into the limbic area. So this is a diagrammatic representation of that, the whole thing, starting from the nociceptor, the first order neuron, the second order neuron or the projection neuron, crossing over, ascending upwards, and in the thalamus, it becomes the third order neuron and ultimately goes into the somatosensory cortex. But there are also pathways that are descending from the brain. These are the descending pathways which could be either facilitatory or inhibitory. I'll talk about it later. Now, before moving on to the perception of pain, let us see what happens to this pain impulse. It can get amplified. The process could be either peripheral sensitization or central sensitization. Now, in peripheral sensitization, the tissue damage that occurs at the skin or whatever the area that is sensing the pain leads to release of tissue byproducts and inflammatory mediators, namely bradykinin, prostaglandins, serotonin, cytokines, HIOs. They form a sensitizing soup around these peripheral nerve endings. And that sensitizing soup increases the excitability and irritability of the nociceptor, which leads to amplification of the pain impulse. Now, the same thing I'm showing here, in which you see that here's a tissue injury. This is the peripheral nerve endings or the nociceptor. And this is the sensitizing soup comprising all these inflammatory mediators and excitatory mediators. And this leads to the amplification of the pain impulse. So the anti-inflammatory drugs, like the various anti-inflammatory drugs like ibuprofen and all, which are the COX inhibitors, are acting at this level by preventing release of the prostaglandins and all these inflammatory mediators. That is how they act, okay? And that is how they're preventing peripheral sensitization. And the degree of peripheral sensitization depends upon the extent of tissue damage. For example, if there's a crush injury where the peripheral sensitization becomes higher and there is a lot of amplification of the pain impulse. There's another phenomenon called central sensitization. While the peripheral sensitization occurs at the periphery, where the nerve endings are there, the central sensitization is amplification of pain in the central nervous system, that is the spinal cord and the brain. There is a state of heightened spinal neuron excitability. That is, there is a hypersensitivity of the spinal cord and the brain. And this can be because of both tissue injury or nerve injury or both. This is because there's ongoing C fiber stimulation is causing a gradual increase in the dorsal neuron firing, causing a state. In this wind up, it is almost as if the volume control is fully on. You see, And the pain is so bad as if the radio is at full volume blaring. So the dorsal neuron excitation and irritability sometimes outlast the painful stimulus. Long after the painful stimulus stops, this dorsal neuron excitation continues to happen. So how it's characterized clinically? By hyperalgesia, that is an increased response to a painful stimuli, or allodynia, which is pain due to a non-painful stimulus like a touch. A simple touch can cause pain, or prolonged pain after transient stimulus, or spread of pain to uninjured areas like referred pain. For example, a patient with migraine, he has got referred pain. You know, they have pain even when combing their hair, or they have pain going down their arms as well, you know, besides the headache. So like this is seen in fibromyalgia, migraine, in CRPS, that is chronic regional pain syndrome. In patients with fibromyalgia, just touching the hand can cause pain. They require, the pain threshold is so low that even just touching the hand can cause very severe pain. That is because of central sensitization. Now, this is a diagrammatic representation of central sensitization. Here, this is a normal pain pathway where there's a normal transmission of the pain impulse, perception, and then there is a normal processing of the pain impulse. But in central sensitization, these red arrows indicate heightened activity at the dorsal root ganglion, at the spinal cord, in the ascending pathway, in the brain, as well as in the descending pathway, leading to an amplification of the pain impulse and leading to the phenomenon of allodynia or hyperalgesia, etc. Now let's come to the perception of pain. The earlier thinking was that pain was perceived in the postcentral gyrus or the somatosensory cortex. But recent research using PET-CT and functional MRI has shown that multiple areas in the brain are responding to a painful stimulus. So that is the, this is the functional MRI picture showing that number of regions other than just the somatosensory cortex are responding to painful stimulus, as indicated in the yellow and the orange color. So the perception of pain involves localization and the intensity of pain, which is caused by the somatosensory cortex. The emotional or the affective aspect of pain is subserved in the limbic area. The motor aspects of pain, that is withdrawal of the hand after an injurious prefrontal cortex. And this is a diagrammatic representation of the same, in which you have the when there's a pain impulse, you have activation of the somatosensory cortex, the limbic cortex, the thalamus, and the prefrontal cortex, as well as the brainstem reticular formation. Now, modulation of pain. The change in the intensity of the pain signal, either dampening or amplification, is called modulation. And inhibition of pain can occur at the spinal level, it can occur at the supraspinal levels, and the various mechanisms that cause inhibition of pain or even the facilitation of pain is because of the gate control theory of pain and the descending inhibitory pathways from the brain. Now, in the gate control theory, when we hit our head, we rub it with a hand to ease the pain. Or a patient undergoes transcutaneous electrical stimulation to decrease pain. Or a child gets hurt, finger is touched jammed in the door. What happens? A child goes to the mother puts the hand around the child, and the child stops crying. How can you explain this phenomenon? This can be explained by the gate control theory. It explains how pain is modulated at the spinal level. And this was first proposed by Melzack and Wall in 1965. In which they said that there's a neurological gate at the dorsal horn of the spinal cord in the substantia gelatinosa. And this modulates the pain impulse before it can reach the higher centers. Now, this is a diagrammatic representation of the gate control theory of pain. Here, this is the pain that is coming through the C fibers, and it is entering the dorsal horn where it is going into the projection neuron, like I explained. And then when the gate is open, that is in the spinal cord in the substantia gelatinosa, this will ultimately go upwards towards the brain. But there are some conditions when the gate can be closed. When does that happen? So besides the C fiber stimulation, when there is an A beta stimulation, that is when there's touch. Touch causes activation of the A beta fibers, right? So when there's A beta stimulation as well, then this causes activation of the inhibitory interneuron, which is present in the substantia gelatinosa of the spinal cord of the dorsal horn. Now, these interneurons, what do? They go to the projection neuron and inhibit that so that the gate is closed. So the pain that is coming through the C fibers cannot go beyond the projection neuron because of these inhibitory interneurons, which is causing activation. And this is stimulated because of the A beta stimulation, like touch or electrical nerve stimulus, or reassurance by the mother itself, you see, to the crying child. All these factors will close the gate so that this painful stimulus will not go upwards. Now here again, another diagrammatic representation of the same. Now here the finger is getting jammed with the hammer. Okay, so the gate A delta and C fibers, it is going to the spinal cord, right? Now, at the same time, if you start stroking the skin or applying massage or ice packs or heat, the A beta nerves are stimulated, which is closing the gate so that this impulse is not going up. The other factors that opens the gate and allows pain impulses to go to the brain are even psychological factors like anxiety, depression, inactivity, a chaotic mind, etc. They also lead to opening the gate so that this pain impulse is going up to the brain. But the other factors that close the gate are distraction. Like, for example, the mother holds the baby and distracts the baby, so that can close the gate. Or relaxation therapy like meditation, yoga, optimism, awareness of nature. These are all the factors that can close the gate and prevent this impulse from going upwards to the brain. So this is all about the gate control theory of pain. So like I mentioned, the spinal level, the spinal interneurons, they release these inhibitory amino acids like GABA and neuropeptides like endorphins that are inhibiting the activity of the projection neuron and prevent the impulse from going upwards. Okay. Now, we talked about the spinal level. Now, at supraspinal level also, there is a descending inhibitory pathway that can modulate the pain. And this starts at the periaqueductal gray matter or the rostral ventromedial medulla, which contain a high concentration of opioid receptors and endogenous opioids like endorphins. And these pathways project to the dorsal horn of the spinal cord to inhibit pain. And the inhibitory neurotransmitters that are involved in this descending inhibitory pain pathway are serotonin, norepinephrine, GABA, and endorphins. For example, the SNRIs, that is the serotonin norepinephrine receptor inhibitors, or the tricyclic antidepressants, or the SSRI, or weak opioids like tramadol and tapentadol, or even stronger opioids like methadone, they all act by inhibiting the reuptake of serotonin and norepinephrine and increase these levels. And that is how they activate the descending inhibitory pathway of pain and decrease pain. And that is how they are all effective in particularly the neuropathic pain. Now, perception of pain, ultimately, how does it happen? Ultimately, it's the activity of the primary efferent neuron, the interneuron in the dorsal horn of the spinal cord, and the descending modulatory pathways that determine the activity of the projection neuron. And pain perception is thus the ultimate result of complex mechanism at various levels of the nervous system, which modulate the original pain impulse. So now let me switch gear and go on to what is palliative care. Now, pallium in Latin means cloak or cover. It is actually the symptoms are covered with treatments whose main aim is to promote patient comfort and alleviate suffering. That is why it is called palliative care. Now, in the WHO definition of palliative care is an approach that improves the quality of life of patients and their families facing a problem associated with a life-threatening disease. How is it done? It is through the prevention and relief of suffering. And what are the means? By early detection, impeccable assessment, and treatment of pain and other problems, which include physical, psychological, social, and spiritual. So this, in a nutshell, is what is palliative care. Is palliative care the end of life care for the incurably ill? No. It is for any serious health-related suffering. In fact, it is a continuum. It starts right from the diagnosis when there is a curative care, but even when the chances of curative care lessens, the impact of palliative care increases. And ultimately, it is going into the end of life care, and then gradually it is coming down during the bereavement period. It is not suddenly stopped, but it is only gradually tapered. So palliative care is started along with curative treatment wherever the oncologist and the palliative care physician can work together. Now, is it only for the terminally ill patients with cancer? No. It is for any patient with a life-threatening illness or a serious health-related suffering and is bedridden, like patients with HIV/AIDS, stroke, those with spinal cord injury with paralysis, advanced Alzheimer's, and even the elderly population. The world is changing. In May 2014, the World Health Assembly, which is a decision-making body of WHO, for the first time passed a resolution declaring that palliative care should be an integral part of all healthcare. And according to the international human rights law, countries have to provide pain treatment medications as part of their core obligations under the right to health. And failure to do this is deemed cruel, inhuman, and degrading. And WHO has now developed policies and strategies to treat it with an emphasis on total pain management. So the principles of palliative care involves the following. It affirms life and regards dying as a normal process. It neither hastens nor postpones death. It provides relief from pain and other distressing symptoms. It integrates the psychological and spiritual aspects of care and offers a support system to help patients live as actively as possible until their death. Now, I just want to bring in a case scenario. A 71-year-old man with a CA of the ascending colon with peritoneal and liver metastasis on chemotherapy since 2 years. He developed ascites and acute intestinal obstruction with pain in the abdomen due to progression of the primary lesion. He was taken to the ER and admitted for conservative management of intestinal obstruction. A Ryle's tube was inserted, tapping of ascitic fluid was done, and an ileostomy was done. And he was discharged with ileostomy, continuous drainage of ascitic fluid, and Ryle's tube for palliative care. Initially, he was taking the WHO step 1 and 2 through the nasogastric tube along with adjuvants. But the abdominal pain persisted and he was started on step 3 drugs orally. But one day he pulled out his Ryle's tube and he did not want it reinserted. There was a family discussion as to how to feed him, how to give him his oral medications, including the opioids, because he had become extremely emaciated and weak. However, we respected the patient's wishes and decided not to reinsert the Ryle's tube because of patient autonomy, which is one of the ethics of palliative care. So he was started on IV fluid dose Chemoport, but the pain grew worse. He was started on transdermal fentanyl patch. Even we gave him transmucosal fentanyl citrate as lollipops, but there was no relief and he was in extreme distress. The family also was distressed. So what do we do? Now, I mentioned about the total pain management, which involves treating the physical pain, the psychological pain, the social pain, and the spiritual pain. So let us see in this particular patient how we could have managed. So what is now recommended is a multimodal interdisciplinary management of pain, which involves medical management, pain interventions, physical therapy, psychosocial management, as well as other therapies like occupational therapy, care of nutrition, etc. The multimodal management of pain was first proposed by Kellett and Dahl for treating post-operative pain in 1993. And the rationale for multimodal management of pain is giving a number of analgesics which act at different parts of the pain pathway. So there is an additive and a synergistic action. But at the same time, it reduces the side effect of any particular drug, as well as it lowers the dose of the various analgesics. That is a rationale of giving paracetamol with morphine because it has an opioid-sparing effect. So the various combination of analgesics include the non-opioids, the opioids, adjuvants, sedatives. So you can give Not just one particular drug, but we give a combination of all these because they act at different levels. And this can be combined with pain interventions and non-pharmacological therapies. So how do we treat pain and other symptoms? 30 to 70% of patients with cancer have pain during the course of treatment, and up to 70 to 90 patients have pain during the terminal stages. Now, pain can affect the quality of life. It can affect their work, their daily activities, their social functioning. It has psychological effects like fear, anxiety, depression, decreased sleep, and impair the appetite. Now, pain and cancer can be not just nociceptive because of tissue injury, but there could be a neuropathic component as well, where the peripheral nerve and the spinal cord and brain is also affected. So there's a lesion here also. Or it could be mixed when both nociceptive and neuropathic. So you need to differentiate between it and treat accordingly with either nociceptive drugs or neuropathic drugs or a combination of the two. The WHO analgesic ladder was devised in 1986, and using this ladder, nearly 76% of patients with cancer can have relief of pain. It is very suitable for home care because all these drugs are given orally and it can be given by the caregiver. So the main features of the WHO ladder is that the drugs are given by mouth. It's given by the ladder starting from step 1. It's given by the clock. It's individualized to the patient, monitoring for any side effects, and adjuvant drugs can be added at every step of the ladder. For severe pain, we go up to the third step, which is the oral opioids, and in our country, morphine and methadone are available as well as fentanyl patch. Now, they're all controlled drugs and require a special prescription. And the NDPS Act, that is a Narcotic Drugs and Psychotropic Substances Act, which was passed in 1985, made it very difficult to access opioid drugs. And its consumption declined because of the tough laws and bureaucratic process. The aim was actually to prevent the misuse and abuse of opioids, but it actually had difficulty in ultimately reaching the patient. So in 2014, there was an amendment to this, and the government relaxed the rules for procuring morphine, and it's now available at all licensed hospitals and recognized medical institutions. And this has made a big difference in the treatment of severe pain and cancer pain patients. And it should be remembered that if it is prescribed by the doctor for pain management, there is no fear of addiction. How do we give the analgesics? Orally is the most common route. All the WHO drugs are given orally, but you can also give these drugs rectally, transmucosal, transdermal, subcutaneous, either as a bolus or in continuous infusion, or the patient-controlled analgesia pumps. It can be given intravenously, epidurally, and even intrathecally as well. But besides pain, there are other symptoms in cancer patients. These include breathlessness, nausea, vomiting, bed sores, delirium, sleep is disturbed, general weakness, low appetite, and constipation. So many other things. They also have to be addressed by the palliative care team. Now, the role of pain interventions in WHO, the WHO analgesic ladder was modified to add a fourth step. This fourth step includes the various pain interventions that we can do for patients who do not respond to the step 3 drugs. So you can give nerve blocks, epidurals, patient-controlled analgesia pumps. You can do neurolysis, that is neurolytic blocks, spinal cord stimulators, or intrathecal opioids. So these are for those 10 to 15% of patients who do not respond to the step 3 drugs. But have we been too drug-centered or intervention-centered in our approach? What about non-pharmacological interventions like dry needling, acupuncture, biofeedback, reassurance, counseling, or physical modalities? The various physical modalities in palliative care include ambulation, musculoskeletal therapy, neurological therapy, electrophysical agents, mechanical therapy, education, etc. And the modalities used include heat, cold, TENS, teaching how to do the activities of daily living independently, and exercise to maintain the functional range of motion. Psychosocial issues. There are a lot of psychosocial and spiritual issues in cancer. They include fear, anxiety, depression, anger, guilt, financial issues, fear of the future, concern about loved ones, loss of role or role reversal, and even questioning God. So for this, you can have various psychotherapies like counseling, communication, medications, support groups which teach art and music therapy, dance therapy, and even providing financial support. Now let's come back to our case and let's review the cause of pain. One of the important causes of pain was probably medical because of progression of disease, and also because probably the oral route and the transdermal route were no longer effective. But were there psychosocial concerns in this patient? Anyway, he was admitted to the hospital. It was found that the ileostomy had become necrotic and non-functional. That was obvious cause for the severe pain. So he had physical pain. So the root conversion was done. He was started on fentanyl infusion, and ultimately he passed away 2 days later, who was relatively pain-free. Now, the psychosocial concerns. This gentleman was a highly educated retired engineer, very well read, and also an artist. He had no financial concerns as the cost of medical treatment was entirely reimbursable. He had a very supportive family of wife and 2 grown-up children who were working in good jobs. So no financial issues. And his wife was a main caregiver, and she had taken the role of head of the family, managing all the affairs of the household. But if we looked at it closely, there were a lot of psychosocial concerns. He was depressed because he knew there was no cure and he would not live long. He had a sense of hopelessness, helplessness, and powerlessness. He had given up his favorite hobbies, reading and art. He had experienced loneliness and isolation because he had withdrawn from friends and relatives for 2 years. He had a low self-esteem. He was totally dependent on his wife, even for self-care activities. He had a feeling of guilt because his wife had given up her job, so she could become his full-time caregiver. There was a role reversal. His wife had taken over all his responsibilities. And there were also social issues because both his children were not married. So for this gentleman, besides treating physical pain, we need to approach a multimodal approach which would address these psychosocial concerns as well. So if you look at the WHO ladder, in step 1, step 2, step 3, you notice that psychological counseling is done at every step of the ladder. Even when you go to the 4th step, which is the interventions like intrathecal opioids or anything you're giving, spinal cord stimulator, again, psychological counseling is there. And then, of course, there are the central neurodestructive procedures like rhizotomy, gangliotomy, and cingulatomy. They are very high-risk procedures, and the risk is actually far outweighing the benefits. But even in those patients, you need to do psychological counseling. That's a very important aspect of palliative care. So if you look at palliative care services, besides medical services like inpatient, outpatient, and home care, there is very important is the nursing services, the psychosocial services, the rehabilitative services, and the supportive services, which include bereavement support, recreational support, children's support, financial support, etc. So together, we can all make a difference in the quality of life of patients requiring palliative care using a multimodal interdisciplinary approach. So that's about my presentation. And any questions I'm ready to take, and over to Ashok.
Thank you very much, ma'am. Yeah, as it was last year, the presentation was very useful, and actually for me, it's like a refresher course. So I was very happy to sit through the entire presentation. So I had we had mentioned in the beginning of the session. I'd like to repeat that. At any point of time, if you have any doubts, you can put it in the chat window, and we can deal with it at the end of the session. And now also, if any of the participants has any doubts to ask ma'am, you can just unmute yourself and you can ask.
There are about 20 minutes left. I was in time. I thought I will not complete my presentation in time, but I managed to stick to the time.
Would anyone like to ask any questions? Dr. Ashwin, Dr. Lakshmi?
This is Dr. Vinayak. Can I talk to
Yes,
ma'am?
please.
Ma'am, just asking very basic. The steps of the pain relief, that is step 1, step 2, step 3, and I learned today step 4 and step 5. How they are actually come into place? Like, was it any defining thing? Because I know that what is there in the first step 1. What was the rationale of having those steps in WHO? Just
This WHO energetic ladder is based basically on the intensity of pain. So if the pain is mild, that is a visual analog, the NRS rating, numerical rating score. We have a numerical rating score or a visual analog scale. If the score is around less than 4, it's called mild pain. So we start with step 1. Okay, so the first and foremost thing one has to do before applying the ladder is to gauge the intensity or the severity of pain and also know the type of pain. Is it a nociceptive pain or a neuropathic pain or both? So if it is a mild pain, then you start with step 1 drugs. And then if it is not responding to it, then you go up to the step 2, which is basically for moderate pain, which is around, say, 5 to 7. If it is not responding to step 2, then only we go to the step 3 drugs. At the same time, you can add adjuvants at every step of the ladder, whether it is a neuropathic pain or a bone pain or pain due to intracranial metastasis, or is there a sleep deprivation, anxiety, constipation, etc. You keep adding adjuvants at every step of the ladder. So this ladder, I find it very, very useful in treating not only cancer pain, but also any acute pain, like post-operative pain or pain due to a fracture or trauma, or even non-cancer pain, you can apply this ladder. So it's all based on the intensity of pain, and the adjuvants are added depending upon the type of pain. So it's very important to assess the pain before you can apply the ladder.
Just adding to that, I think one thing that Dr. Vinayak wanted to know was how it came into being, how the ladder came into being.
Okay.
So what I feel is there are a lot of ladders, there's a ladder for a control of bronchial asthma also. So in situations in which the issue is measurable, like in pain also, it's fairly measurable with the analgesic ladder, analgesic visual analog scale, for example. So a certain amount of pain is present, and basically a ladder just means a step-by-step approach to dealing with that. So that is why whoever came up with the ladder came up with such a system.
And the ladder was also for another reason. Before 1986, a lot of people were dying with pain because people were afraid to prescribe strong opioids, and people were afraid to take the opioids as well. Hospitals were not prepared to store the opioids because of the fear that it will become an addiction. And there were so many strict laws about these opioids. When the WHO made the ladder and said that for strong, severe pain, you can give strong opioids, it actually legitimized the use of opioids. And not only legitimized, it also removed the stigma of giving opioids or taking opioids. Okay. So we can say this is what the WHO has prescribed. And because of that, the stigma associated with taking the morphine also had to a large extent gone.
Can I ask a question to ma'am?
Yes.
Yeah, I'm Namita. Ma'am, in some countries, marijuana is being legalized for pain. So what is your opinion on that? And do you think it should be legalized in India also?
Yeah, you know what? Just the other day, 2 days back, I saw something about cannabinoids, that someone had filed a case in the Supreme Court that can we use cannabinoids in pain, because in many countries, cannabinoids are being used for, as an adjuvant, basically. Okay. But in India, we are using it, but it is still not legal. Right. But I've come across people who are using cannabinoid oils and things like that. So there is a role for that. And I think it's a matter of time before we also legalize it. Of course, it has to be, we have to be careful on using it. And this is actually covered in one of the aspects of your, when you deal with step 3 drugs, they will be talking about the use of cannabinoids in palliative care as well.
Thank you.
But in India, there are other ways of procuring cannabinoids, which is not under the table. You can get it. Many people I know are taking these oils, not only for the sleep as well as for the pain.
There is an entire session on opioids.
Yes, strong opioids.
Yeah, it will be dealt with in that session.
What I said is basically an overview. Ultimately, all this will be dealt with separately.
Do we have any other questions? So I think we can, by the way, please, I need to tell everyone, this is a very informal session. Please feel free to ask any doubts to ma'am, because I mean, there is no inhibition required here. Anything at all you can ask. I'm saying this because I was sitting where you are last year, and I also had the same inhibition to open up and ask questions about this, but then as the topic became more and more interesting, and when yeah, so when I was able to interact more, I was able to gain more. So please, if you have any doubts, please do feel free to ask. If not, we can deal with it in the next session. So if there's nothing else, can we close the session for today? She gave an absolutely comprehensive coverage of what palliative care is, what pain is, and a few snippets on the treatment as well. So the next session will be about proper assessment of pain and the types of pain in detail. Dr. Nitya, yes, you will be sent emails with the entire slides of the presentation. And I think there'll be a recording, there'll be a link to the recording also. Is that correct, Dr. Rajlakshmi?
Yes. The entire session is recorded. We will convert it into a YouTube link and send it to all. So the entire 8 sessions, you will be getting the recorded link as well as the faculty presentation and all the attachable materials that the faculty is giving. We will send it that.
You will get access to all that.